So, good evening, all, and welcome to this session on the medicine residency program. Take it as a teaser for our upcoming medicine residency program, which we believe is one of its kind in the history of online platforms for medical education. So, we have a comprehensive package for MD medicine as well as DNB medicine residents, which will help them to become better physicians as well as clear their theory as well as practical examination. So I will be dealing with the infectious diseases part in this particular medicine residency program. So we have an comprehensive section on infectious diseases. We have 24 videos which are short on antibiotics alone. Apart from that, we have special courses on HIV, tuberculosis, malaria, and other common infections, and covering infectious diseases in total. We also have upcoming journal clubs as well as updates that will be updated on the app. Now, this is just a teaser that we are introducing. The app will be showing the actual curriculum program will be available on the app very soon. So wait for it. And today we will be discussing one particular topic, that is urinary tract infections, a few case-based approach, clinical cases. So our curriculum program is arranged in such a way that we have clinical cases, and case-based discussions are carried out instead of just theory discussions. And you will get a snapshot or a bird's eye view of what we are going to do in the curriculum program as well. So I will be dealing with a few clinical scenarios. The first clinical scenario is a 56-year-old lady with diabetes presents to you with complaints of dysuria, increased frequency, and suprapubic pain. Her urine analysis shows an increased pus cells. Okay. So what exactly is an increased pus cell means? So you have been given a clinical scenario and said that increased pus cell means. Now, pus cells can be tested by various methods, by hemocytometers, flow cytometers, and you can also count them in the sediment or centrifuged urine, which has been done previously. Now, the cutoff for pus cells is 10 leukocytes per millimeter cubes and midstream urine, or 10 leukocytes per high power field. So whatever it is, this particular patient has pyuria that has been given to us. Now, pyuria is non-specific. It is not mandatory that every patient with pyuria has a urinary tract infection. And again, the absence of pyuria should strongly call into question a diagnosis of urinary tract infection. Now, with that, let us go back to our case. So this was a 56-year-old lady with diabetes mellitus presenting with dysuria as well as increased frequency as well as suprapubic pain, and there is increased pus cells in urine microscope. So whenever you have a clinical case that is given to you, or a patient that is coming to you, the first thing that you have to make is to make a clinical diagnosis. So what is the clinical diagnosis in this particular patient presenting with dysuria, increased frequency, and suprapubic pain, in whom there is no mention of fever? Now, there are, in reference to urinary tract infection, there are two clinical syndromes that we should be aware of. One is called as cystitis, and second is pyelonephritis. Now, cystitis refers to infection of the urinary bladder, whereas pyelonephritis refers to infection of the kidneys as well as the ureters. So this is something that is very basic. So infection of the bladder or the lower urinary tract is called as cystitis, whereas infection of the upper urinary tract, as kidney or ureter, is called as pyelonephritis. Now, the cystitis patient presents with dysuria, increased urinary frequency, urinary urgency, suprapubic pain, and hematuria. Now, notably, you can see that fever is not mentioned as a symptom of cystitis. On the other hand, patients with pyelonephritis, apart from the symptoms of cystitis, they will also have features that suggest infection has extended beyond the urinary bladder, which includes fever, which includes chills, rigors, and significant fatigue or malaise, flank pain, and on examination, you may get costovertebral angle tenderness, and also you may get pelvic or perineal pain in males. So that is pyelonephritis. So if there is fever, if there is flank pain or a costovertebral angle tenderness, you have to take it as pyelonephritis. If it is not there, If it is only lower urinary tract symptoms, you take it as cystitis. So this particular lady only had symptoms of cystitis. Now the question is, what do you do next? So further investigation, should you do a urine dipstick test? This is something that is usually done. So there are two dipstick tests that are done usually. This includes a leukocyte esterase test as well as a urine nitrate test. The urine nitrate test is based on the theory that enterobacteriaceae like E. coli and Klebsiella can convert nitrates to nitrites, which can be detected by the dipstick. This test has a sensitivity of 75% and a specificity of around 80%. So it's not a good, like extremely good test. Okay, sometimes you can use it and give some clue, but not a very good test. What about urine culture? Is it always needed in a case of cystitis? The answer is, like when you look at the textbooks, they may say that urine culture need not be done. You can treat them without urine culture also. But in Indian settings where there is an increased risk of drug resistance, it is always better to go for a urine culture. Now, before going to the treatment, again, you know that urine culture will take some 3 to 5 days to come. And how do you treat these patients empirically? For treating cystitis empirically, you should know what is the antibiotic susceptibility pattern in your area. Now, this is the ICMR antibiogram for E. coli, which is the most common organism which causes urinary tract infection. Now, this patient has come with a simple cystitis. And what do you want to treat this patient? You don't want to treat this patient with an intravenous agent. You would like to go with an oral agent. And what oral agent we have? Now, most often it is it's a common practice that you use ciprofloxacin for most patients with urinary tract infection. Now look at ciprofloxacin and its susceptibility. It's only 21% susceptible. So if you're using ciprofloxacin for the treatment of cystitis, 80% of the time you may fail. Do we have any other oral option is the question. Now look at this agent. This is called as nitrofurantoin. It's a urinary antibiotic which achieves excellent concentration in the urinary tract. And look at its sensitivity. It's around 91.3% of the isolates are susceptible, making it the excellent choice for treatment of acute cystitis in our setting. You have another antibiotic which is called as fosfomycin, which can also, there is an increased susceptibility, there is 96.9%. It can also be used. Now, for treatment of acute cystitis in Indian setting, if you have nitrofurantoin, that will be considered as a drug of choice, which can be given 100 milligrams BD for 5 days. So this is the treatment of acute cystitis. Trimethoprim sulfamethoxazole, the susceptibility around 40 to 50%, not chosen as the first line regimen in India. But if you have a proven susceptibility, trimethoprim sulfamethoxazole, one double strength tablet can be given for 3 days. It is also an excellent drug, but susceptibility has to be proven. Fosfomycin, again, has been found to be almost equivalent to nitrofurantoin for the treatment of urinary tract infection, that is cystitis. You can give it as a 3-gram powder, that is a single dose can be given. But again, in Indian setting, fosfomycin is used for the treatment. Intravenous fosfomycin is used for the treatment of severe gram-negative infection. So I would like to reserve this particular drug and not to be very commonly used. So the drug of choice here will be nitrofurantoin. You can give 100 milligrams BD for 5 to 7 days. Now, there are some things that you have to be taking care when you are giving nitrofurantoin. Nitrofurantoin, when you're giving in impaired renal function, do not give it when the creatinine clearance is less than 30. Creatinine clearance is less than 30. Do not give. G6PD deficiency is another contraindication where it can cause hemolysis. Again, it should not be given in the first trimester of pregnancy as well as near term. So these are some contraindications for nitrofurantoin. Other than that, it's an excellent drug, achieve excellent concentration in urine. But mind you that nitrofurantoin has very poor concentration in the blood. So it is a good drug for cystitis. But when you need good concentration in the blood as well as the renal tissue, it's a poor antibiotic. So it should not be used in patients who have pyelonephritis. So what about the alternative options like amoxicillin, clavulanate, cefpodoxime, cefuroxime, cephalexin, ciprofloxacin, etc.? So they should be used only if these agents are not available. So oral beta-lactam agents are not very good agents for the treatment of urinary tract infection. Use only if you don't have nitrofurantoin available. Against ciprofloxacin, we have already mentioned, not to be used as an empirical therapy. You may fail more than 80% of the time. So If susceptibility is proven and the other drugs are not available, you can give 500 milligrams BD for 3 days. And so what about follow-up cultures and follow-up urinary examination? It's a common practice to do all these tests. So there is no indication to do a repeat urine test to see if the pus cells has resolved. There is no such indication. Again, you don't need not repeat urinary culture also if the patient has clinical improvement. So you just need to follow up these patients clinically. No need for a repeat urine testing or a urine culture. What about pregnancy? What if these patients had presented in pregnancy? So this is again a common presentation that many patients in pregnancy can present with features of cystitis. Nitrofurantoin again remains a good drug which can be given 100 milligrams BD for 5 to 7 days. Typically, as we have already mentioned, it should be avoided in the first trimester, as well as we should avoid at a term where there is a possibility of hemolytic anemia in the newborn, which can be precipitated by nitrofurantoin. The second drug, trimethoprim sulfamethoxazole, one double strength tablet you can give for 3 days. Again, this also should be avoided in the first trimester because of the risk of neural tube defects. And again, typically avoided at term because it also can cause neonatal jaundice. Fosfomycin is also safe in pregnancy. You can use the other agents, cefpodoxin, cefixime, amoxicillin, etc. If the organism is susceptible, definitely you can give. Amoxicillin clavulanate also can be used, but it is typically avoided at term because there is an increased risk of necrotizing enterocolitis with amoxicillin clavulanate. Now, the second clinical scenario, here there is a 56-year-old lady with diabetes. She does not have any symptoms, but she had undergone an executive health checkup, and in that she was found to have increased pus cells in the urine microscopy. Now, a urine culture has come, and the urine culture is showing E. coli at a colony count of 10 raised to 5 colony forming units per ml. Sorry for that. So you can see there is E. coli, and E. coli is sensitive to ceftriaxone, cefoperazone, sulbactam, piperacillin, tazobactam, etc. So what will you do with this patient, and what is the clinical syndrome? Again, we look at the clinical syndrome. What is the clinical diagnosis? Now, the clinical diagnosis in this patient who does not have any urinary symptoms but has isolation of E. coli at a colony count of more than 10 raised to 5 colony forming units per ml is called as asymptomatic bacteriuria. Okay, so it's basically isolation of a bacteria in an appropriately collected urine specimen from an individual without symptoms of urinary tract infection. And it should not be at any colony count. The cutoff is you should have at least 10 raised to 5 colony forming units per ml. So at this amount, if you're getting the bacteria, but there is no symptoms, it's asymptomatic bacteriuria. Most patients with asymptomatic bacteriuria should not be treated. There is no indication for treatment of asymptomatic bacteriuria in most of the patients. So routine screening of asymptomatic bacteriuria is not indicated for like executive checkup pre-operatively. Do not do a urine culture to look for asymptomatic bacteriuria. No, can asymptomatic bacteria proceed to UTI? Some patient can ask you. So what will you tell them? It is not that it will not. Actually, it can proceed to UTI. It can progress to UTI. The only thing is that whether you treat with antibiotics, the chance of it going to urinary tract infection cannot be decreased by treatment with antibiotics. You treat it or not treat it, the risk of going into UTI is safe. You have to tell the patient, okay, like the patient may later come and tell you, you didn't treat my asymptomatic bacteriuria, that's why it progressed. No, it's not like that. If you treat it, not treat it, the risk of progression to UTI is the same. So the treatment does not reduce the risk of symptomatic UTI in future, and that is the reason by which we are not giving antibiotics in most patients with asymptomatic bacteriuria. But some doctors may argue that my patient has pyuria. Again, there is no indication. Even if your patient has pyuria, there is no indication. My patient is diabetic. Even then, you don't have indication to treat asymptomatic bacteriuria. So there are only 4 indications for treatment of asymptomatic bacteriuria. The first is pregnancy, because in pregnant women, asymptomatic bacteriuria has been found to lead to one, pyelonephritis, second, preterm birth, as well as low birth weight in the infants. So as a result, pregnancy is one indication and one of the commonest indication where asymptomatic bacteriuria should be screened. Every pregnant female, especially in the first antenatal visits itself, they should be screened for asymptomatic bacteriuria and treated if it is there. Patients undergoing neurological surgery where there is a mucosal bleeding, again, indication. Neutropenic patients, you can treat. Renal transplant recipients, you can treat. So apart from these four, there is no indication for treatment of asymptomatic bacteriuria. Remember pregnancy, because this is one clinical settings, especially that you all are going to face when pregnant females presenting with asymptomatic bacteriuria are referred to you. You have to treat them. It is not like other general population where you don't treat. And in pregnancy, what are the treatment indications what are the antibiotic regimens that you give? It is the same as that we gave for cystitis, the same antibiotics that you can use for these patients who are presenting with asymptomatic bacteria. Also, you can use nitrofurantoin, you can use trimethoprim, salmeterol. Again, remember not to use when they are in the first trimester or term. You can use the other beta-lactam agents as well. So whatever we have mentioned for acute cystitis also holds good for treatment of asymptomatic bacteriuria. We have a clinical scenario 3. So this is the 56-year-old lady with diabetes presenting with fever, chills, and dysuria. The patient has increased pustules in the urine microscopy. So this is, again, the 56-year-old lady, it remains the same. But the symptoms you look, the patient has fever with chills and dysuria. So what is the clinical syndrome here? We have discussed this previously. This patient has features, along with urinary symptoms, the patient has fever, and presence of fever alone. In a patient who has urinary symptoms, you should clinically diagnose it as acute pyelonephritis. Okay. Again, they may have flank pain, they may have costovertebral angle tenderness, but fever alone is required to call it as pyelonephritis. So this particular lady has acute pyelonephritis. Now, this definition also you should understand, there was something called as complicated urinary tract infections previously. Now, the complicated previously, we used to define uncomplicated UTI as acute cystitis in a healthy, non-pregnant, afebrile woman with no diabetes and no urological abnormalities. Now, this definition has completely changed. The definition of complicated and uncomplicated has changed in the recent ID week, that is the International Conference of the IDS, that is Infectious Disease Society of America. This new definition has come. So complicated UTI is any UTI where the infection has spread beyond the bladder. So which means that the pyelonephritis in males or females can be taken as complicated UTI. Catheter-associated UTI or any febrile or bacteremic UTI is taken as complicated UTI. Rest all, whether it be male or female, it's uncomplicated UTI. So this definition has changed, something that you have to keep in mind. Only remember the new definition. Complicated UTI is an infection beyond the bladder, and it's uncomplicated. Everything else, men or women, it's uncomplicated. So in any patient who is presenting with pyelonephritis, what investigation will you do? You will do a blood count, you do a CRP routine, urine routine, and culture definitely has to be done. Blood culture to look for any bacteremia. So every patient with pyelonephritis, does they need an imaging? Not exactly. So patient who have severe disease, like particularly the hypertension, etc., definitely you can go with an imaging. Persistent symptoms despite antibiotics for 48 to 72 hours, again, you can image. If you have a suspicion of obstruction, particularly due to stones or other reasons, again, you can image. Again, if you have recurrent symptoms within a few weeks of treatment, you again suspect an obstruction. So why are we doing imaging particularly? To know whether we need to do some procedures to decrease, to do the source reduction, whether the urologists need to be involved. That is the question. And that is why we are doing an imaging. And imaging, a CT scan is the preferred image in a patient with urinary tract infection if you have an indication for image. So both contrast as well as non-contrast CT should be done in these patients as a part of imaging. Again, every patient does not require image. So we have mentioned what are the indications for imaging in a patient with urinary tract infection. That is pyelonephritis. The patient is presented with pyelonephritis, run the investigation, but you have to start with an empirical treatment. Now, what antibiotic will you choose? There are certain factors that you have to decide when you are starting antibiotics for the patient with urinary tract infection. First, what is the hemodynamic status of the patient, whether the patient is in sepsis or not. Now, second, what is the risk of resistant organism in this patient? As the patient being recently exposed to antibiotics, as he had recent hospital admissions. Again, patient-specific factors like his renal function, other factors, allergies, etc. Again, you have to consider the local antibiogram to know what are the commonest organisms which will cause urinary tract infection and what is their antibiotic susceptibility. Now, again, we come to the antibiogram what the ICMR has published for E. coli. I'm choosing E. coli because it's the most common cause of urinary tract infection. So you look at the agents. So can you use ceftriaxone? That is one question. Can you use ceftriaxone as the empirical agent for the treatment of urinary tract infection? If you look at the susceptibility, it's only 30%. So if you're using ceftriaxone as the agent for treatment of acute pyelonephritis, you may fail in 70% of the time. Now, the second agent, for example, if you can look, piperacillin tazobactam is given as 63%, but it changes from places to places. For example, in my place, we have excellent susceptibility to piperacillin tazobactam as well as cefoperazone sulbactam, like more than 90%. For you, we use these agents as the primary agents if the patient is not in sepsis. And look at the other agents like ertapenem. So ertapenem is like around 80% susceptible. So if you look at the other like meropenem, it is around 87.7% susceptibility is there. So as an empirical agent of choice, if the patient is not in sepsis in Indian setting, you can either give piperacillin tazobactam or cefoperazone sulbactam as the initial treatment. If the patient is in sepsis, you may choose a carbapenem, meropenem, ertapenem, or imipenem can be given as the first-line agent for the treatment. Again, if the organism is susceptible, even piperacillin tazobactam or cefoperazone sulbactam can be chosen for the treatment. But if the patient is sepsis, particularly hypotension, and particularly if the patient has bacteremia, that is, you isolate the organism in the blood, carbapenem may be preferred. Otherwise, stable pyelonephritis, if you can wait, before escalating to carbapenem, cefoperazone sulbactam, 3 grams BD, that is the dose, not 1.5 grams BD, or piperacillin tazobactam, 4.5 grams IV 8th hourly. Another dosing regimen is 3.375 grams given 6th hourly also. So these dosing regimens that you can use, and again, as in sepsis, we have already mentioned. Now, what if the patient is clinically improving? You have started the patient on, say, cefoperazone sulbactam, and the patient is clinically improving. And what does clinically improving mean? Clinically improving means the patient is afebrile or his fever is coming down. Definitely, the patient has become hemodynamically stable, his BP is okay, there's no supports, and source control, if needed, has been achieved. That is, if there is any stones, it has been, stenting has been done, if there has been an abscess, drainage has been done. So if these 3 criteria are met, that is the patient is afebrile, hemodynamically stable, and the source control has been achieved, then you can assess the patient for oral options. That is something that you have to be aware of. Not every patient with urinary tract infection, you need to complete the course with intravenous agent. Some of these patients actually may be eligible for oral therapy. That is very, very important. And you can switch to oral agents if they are eligible. Now, again, we have to be very, very careful when you take an oral agent. So you have to look whether the bacteria is susceptible to an effective oral agent. So it should be active against the isolated bacteria. So the bacteria should be susceptible to the drug and achieve adequate levels in urine, tissue, and blood. So you cannot use nitrofurantoin to complete therapy for a patient with pyelonephritis because it does not achieve adequate level in the tissue or blood. Okay. And you should also look at patient consideration, the patient able to take orally, and whether the patient has any contraindication for the drug. 2 excellent drugs which can be used for oral step down is, one is ciprofloxacin, if it is sensitive, okay? If it is sensitive, quinolones are excellent drugs. And second is trimethoprim, sulfamethoxazole, again, if it is sensitive. If these drugs are sensitive, you can change to this drug and discharge the patient home for pyelonephritis. After 2 to 3 days of IV therapy, you give this drug and complete 7 days of IV therapy, total antibiotic therapy. Okay, so total duration of antibiotic therapy in patients with urinary pyelonephritis is 7 days. Okay, in patients who are clinically improving, The treatment duration is 7 days. It's not 10 days. It's not 14 days. It's 7 days. And you can shift to oral if an appropriate oral agent is available. Now, this is another question. A 48-year-old female patient with uncontrolled diabetes mellitus presenting with complaints of fever of 5 days duration associated with chills and flank pain. On examination, the patient is in hypotension. So blood and urine culture. Okay, now look at the clinical scenario. Diabetes mellitus, fever, chills, flank pain. So you diagnose what? You diagnose pyelonephritis. That's your clinical diagnosis. Then you get the culture reports. Organism is E. coli. Okay, it's sensitive to ceftriaxone. Okay, sensitive to ceftriaxone. It is sensitive to penicillin tazobactam also, but sensitive to a narrower agent like ceftriaxone. You can use ceftriaxone, but you are also given another imaging, that is the CT of the abdomen. I mean the CT of the kidney, uterine, bladder. So what do you see in this particular CT scan? So you have the right kidney here, you have the left kidney here. So what do you have? So this particular patient has in the kidney, you can see these black areas. So there is air in the kidney. So air in the kidney. So this is a clinical condition which is called as emphysematous pyelonephritis. So this is a serious form of urinary tract infection, a pyelonephritis, where there's formation of air in the renal tissue, which is emphysematous pyelonephritis. So emphysematous pyelonephritis, antibiotic, it's the same as that of, you can use like any other urinary tract infection. Here, ceftriaxone is susceptible. You can give ceftriaxone. Again, you can also shift to oral agent for after clinical improvement. But unlike other pyelonephritis, the duration that we usually give is for around 2 weeks. Again, if the patient has gas in the renal parenchyma and it's extending to the extra-renal space, a percutaneous drainage should also be done in addition to the antibiotics. That is very important. If the emphysematous pyelonephritis or the emphysematous necrotic tissue is like in a large amount, you should do a percutaneous drainage. Unless it's a very small, discrete area of air, there you can treat it with antibiotics alone. But in most of the cases, you do a percutaneous drainage also. Coming to the last clinical scenario is a 56-year-old lady with diabetes presenting with complaints of dysuria and increased frequency. So there is increased vessels in urine microscopy. You have diagnosed acute cystitis and you're treating it. The problem is that the patient has similar episodes in the last 6 months to similar episodes, and she's asking you, what can I do to prevent it? So what is this particular clinical syndrome? So she has acute cystitis, but again, she had more than 2 episodes of UTI, okay, 2 or more episodes of UTI in 6 months, or 3 or more episodes of UTI in 12 months. You call a clinical scenario as recurrent cystitis. Recurrent cystitis is a very common clinical scenario, a disturbing clinical scenario that is common in females. Again, they may come to you and ask, what should I do? Like, what treatment should be taken, or how do you prevent this particular clinical scenario? Now, again, it has been known to us that like all of our elders used to, or our grandparents used to tell children, you take a lot of water, that will prevent urinary tract infection. So can you tell that to the patient, or is it scientifically proven? In fact, a randomized controlled trial was done on this particular thing. So there was one group in which they were asked to take an additional 1.5 liters of water per day, okay, in addition to what they were usually taking. So one arm got 1.5 liters of water extra, the other arm the usual water intake. And what they found, that the group in which there was additional water intake, there was fewer episode of cystitis, and they required fewer antimicrobial course. So what does that mean? So you can tell the patient to take additional water, okay? Drink plenty of water, up to 3 liters or something like that, in 1.5 liters, in addition to what they are usually taking. Second, cranberry products. You see a lot of cranberry products in the market. Do they have any benefit? In fact, they have. This is a Cochrane meta-analysis, okay, in which they found that the cranberry products actually reduce the risk of symptomatic culture confirmed urinary tract infections. Okay, so recurrent urinary tract infection in patients who have recurrent UTI, cranberry products is something again that they are available as tablets in the market, can be prescribed to the patient. So the mechanism is that these cranberry products have something called as protoanthocyanidins, which can bind to a P. fimbriae on the E. coli. Okay, P. fimbriae on E. coli. Now, this P. fimbriae is used by E. coli to bind to the uroepithelial cells. So this is blocked by the protoanthocyanidins, or sorry, proanthocyanidins. So again, there is some indication or there's some evidence to suggest that cranberry products have some role in prevention of recurrent urinary tract infections. And again, some patients, they will not improve on all these measures. They'll get recurrent urinary tract infections. And if they satisfy this criteria of recurrent urinary tract infection, you can give them antibiotic prophylaxis also. So what are the antibiotic prophylaxis that we have? Again, nitrofurantoin is the drug of choice again, because most of our E. coli are sensitive to nitrofurantoin. So the prophylaxis can be either continuous or post-coital. Now, continuous is given for most of the patient, but some of the patient may have recurrent UTI, which is particularly precipitated by sexual intercourse. In such patients, you can go for a post-coital prophylaxis. So if it is not post-coital, it's a continuous prophylaxis, you give 100 milligrams once daily. It's usually given for an indefinite period, 3 to 6 months, sometimes years also. Nitrofurantoin is prescribed. Now, post-coital prophylaxis is given to patients whom the recurrent UTI is precipitated by sexual intercourse. There you need only to give 100 milligram, one single dose after the sexual intercourse. Now, next is trimethoprim salmeterol as a prophylaxis. You give a half tablet, that is a half single strength tablet given daily, again 3 to 6 months or even longer. Postcoitally, again half single strength tablet given just as a single dose. Oral cephalosporins can also use, like cephalexin can be given 250 milligram once daily, or cefixime can be given 200 milligram once daily, etc. Fosfomycin is given for usually for resistant organisms which are resistant to the usual antibiotics, which you can use fosfomycin 3 grams given every 7 to 10 days. So this is a treatment options or the preventive options for recurrent urinary tract infection. You can attempt increase fluid intake, cranberry products, but some patients will definitely need antibiotics, and where you can use nitrofurantoin, Septran, or oral cephalexins, either as a continuous prophylaxis or a postcoital prophylaxis. So this is just a case-based discussion on urinary tract infections. And we have similar case-based discussions as well as theory discussion on various clinical syndromes. As we have already mentioned, we have an entire section on antibiotics where each antibiotic is discussed with clinical scenarios, where they should be used, what modification should be done in various clinical scenarios, and what should you take care before giving antibiotics. So we have an entire section on antibiotics. We have sections on clinical syndromes, various clinical syndromes. We have an entire section about 8 videos of HIV medicine, tuberculosis. We are on 4 to 5 videos of tuberculosis. And so all of these are discussed in detail. The primary objective of the medicine residency program is to make you better physicians, and not just a clearing exam, to make you better physicians. Definitely exams are to be cleared, and you will be given particular training for both theory exams as well as practical exam in this particular curriculum. And also there will be journal discussion. So that is something that every medicine resident should be aware of. So we have to be updated on whatever is happening in our field. So major journals article which is being published in the particular area will be discussed by the doctoral faculty. So we intend to make a comprehensive package for the MD medicine residents. I hope you all will benefit from that. Thank you. So I'll take any questions if something is asked. Somebody has asked how to improve urine flow in UTA. Again, I don't think that is like an issue, something that we need to address, a urine flow and urinary tract infection, unless you have an obstruction. If you have an obstruction, that obstruction has to be relieved. So that you will have to call your urology friend. If a stone is there, something like strictures are there, sometimes you have to go for a DJ standing, etc. So that is how you have to improve, relieve the obstruction. But urinary flow to increase, I don't think you need to give anything. So I don't think we have more questions. I think we will stop with that, and we will have further discussion in the app. So let's all meet there. Thank you.